Okay, we're going to get started. People, as always, may filter late, that's okay. I want to welcome everyone to the first fall edition of Medical Grand Rounds. My name is Chris Martin. I'm one of our intensive care physicians and the Director of Medical Education here at RVH. Couple of housekeeping things. First of all, you see on front of you on the table is a QR code. We want feedback on the session, both from the speaker, but also just from Medical Grand Rounds as a whole. We're always looking to improve it. I always want to thank people who made this possible. Midstream, Irish Lakehawk, and Amy Dempster. Yeah, we're excited to have one of our homegrown physicians here, Dr. Mahdavian, who's going to be speaking about COPD management. I get the pleasure of introducing Masoud. So, Dr. Mahdavian is a respirologist and sleep medicine specialist who's been here at RVH practicing since 2018. He has fellowship in general internal medicine from UT and did a respirology fellowship at the University of Ottawa. He has a master's degree in clinical epidemiology, COPD, from the University of Sherbrooke in Quebec. He's interested in airway disease and a member of the Asthma Steering Committee of the Canadian Thoracic Society. He's currently involved in the Asthma Guidelines Committee, the new CTS Severe Asthma Guideline publication. He is an adjunct clinical appointment at the University of Toronto. So let's put our hands together and welcome Dr. Masoud.
So for the introduction, and this was for today. We talked about the important disease COPD, and the name is those this topic for is that it's very common. The prevalence and also hospitalization is one of the most common reason for hospitalization in Canada. I should mention my disclosure. Inquiry bias with different pharmaceutical companies. The objective for this talk today is to understand the effect of COPD association on cardiovascular disease. I mainly focus on both COPD and also effect on cardiovascular, and also how we can reduce the mortality of COPD. In the past, there was no medication to reduce the mortality. Nowadays, we have to put medication to reduce the COPD mortality. This is the reason that COPD guideline in Canada, especially the Canadian guideline, has changed significantly over the last year. And also, we're going to go beyond the inhaled therapy and talking quickly about the biology therapy in COPD as well. I'll start with a case. It's one of the cases I saw. Sam was 57-year-old. He died with COPD 5 years ago based on the KFT. You know that we cannot diagnose COPD based on the history of physical examination, but the only way to diagnose COPD and can clear it is based on the KFT. He also has some coronary artery calcification, noticed the CT scan of the chest, history of high blood pressure, and hypertension. For his COPD, he is already on trilogy and take samples from as needed. And take valves for blood pressure and fasting as well as because of the coronary artery calcification. He's 55 years old, but retired vascular research. Obviously, as faster when he was exposed to pharmaceutical as well. And still smoking 25 pack here, living in a house with a wife and 2 dogs. Comes to your clinic or you see a patient in there, complaining of still out of breath, and it's worse than before. And it reduces his tolerance for activity. The MMRC2, I will explain what does it mean. MMRC2 means that when the patient walks on flat level for more than 100 yards, get the patient shortness of breath. And had to recent emergency department visit. Just by being on a trilogy, had to emergency department visit. How we can reduce this and improve the patient's symptoms. In your physical examination, quite a stable white blood cell at the baseline, but you notice the oxygen saturation at rest around 90%. And there was a bilateral reduced without any advantageous treatments, no easing or practice. Physical examination I mentioned, and the blood work you do looks good, but also to 0.3. I don't know if it's good or not. And check for the alkaline frequency was right in the normal range. This is the breathing test, the last one he had. The FEV1 is obviously, like mentioned, just post-mortality to show the patient has COPD, confirm that. And FEV1 is around 60%, which is a moderate airflow obstruction. And the DLCO again reduced, and RV is elevated, shows that most of the patient has more than this COPD. Why do you have that COPD? If you look at the patient comes with COPD exacerbation, comes to the emergency department requiring hospitalization. In 5 years, 50% of them, 50% of the patients you see in the hospital active with COPD are from 11 years. 1 in 2 people. This one study, another study I saw from 120, 1/3 of people died in 3 years. If the patient comes with COPD exacerbation comes to the emergency department or hospitals. Huge mortality. The other reason is, if you look at the non-hospitalization, in 2019 to 2020, was the second common cause for hospitalization in Canada. After the childhood, I don't think the childhood is a disease. Asthma is a normal human behavior. As a disease, COPD was the most common reason for hospitalization. In 2023, dropped. What do you think about that? Once the COVID came, obviously we had more hospitalization. But people with COPD, they had a risk. They had a kind of social isolation. It's reduced significantly the risk of infection and COPD exacerbation. If we look at the person with the COPD exacerbation, we know that every time patient gets the right side, COPD exacerbation, it reduces the interval to the next COPD exacerbation. We get much sooner exacerbation. The other thing is that they lose some degree of their lung function. Many of them, they never recover to the baseline. Every time they lose the COPD exacerbation, the interval goes less and less, but with exacerbation, gradually lose lung function, it increases the mortality. It's very similar to the picture the cardiologist is showing for heart failure decompensation. It's exactly the same. When the person has heart failure decompensation, interval for the next decompensation gets shorter and the mortality goes down. If you look at the number of exacerbations on the left side, you see if the patient has more exacerbation, it increases it reduces the problem of the serious mortality. Patient only had group A was the no exacerbation. B is the group had only 1 or 2 exacerbations of COPD. C with the brown color is 3 or 4. As you can see, the mortality is huge. How we can expect for a patient comes to our clinic, which patient also has more exacerbation. One was the person with history of exacerbation. The second is, if you look at the patient symptoms, this one shows that if the patient has symptoms of short start, if the MMR sees 2 or more, which means that if the person has short start, walking on a flat, they have much higher risk of exacerbation. Almost twice moderate to severe. For the severe, is more than 4 times increase in risk of exacerbation as moderate severe exacerbation. If you reduce the symptoms, also it means that we can reduce the risk of exacerbation. The question came, does it matter if the patient has mild COPD or severe COPD, essentially they are patient? This study shows us how much lung function the patient loses every time after the exacerbation. Even if the patient has a mild COPD, which means that FEV1 was more than 80% by the normal range, but the ratio is low. They have much higher loss of their lung function. As the COPD goes much higher and higher grade, when FEV1 is less than 50%, they may lose less lung function because they don't have any reserve to lose. When the FEV1 is around 50 to 60, 600, 500, there is a much more to lose. It was even 15 to 30 milliliters is significant. But even in mild patient, they lose lung function, and the lung function is a surrogate for the lipid surface. This is like what I showed at the chance of exacerbation based on the patient severity of COPD. Again, even if it's a mild stage 1 reflux COPD, still there's a good risk, 30% risk of hospitalization or exacerbation. It's huge. We need to pay attention and treat the patient even in mild COPD. We don't want to be reacting to what happens at the area. We need to be proactive and treat the patient within the mild stage to prevent further damage to the lung and more hospitalization and risk of death. This is a vicious cycle of even happens in patient with COPD. When the patient has COPD, they have airflow limitation, they get shortness of breath. One of the things, this is not just for anyone. When people have shortness of breath, natural reaction is they reduce their level of activity. When they reduce their level of activity, they lose their muscle function. Then they get gradually more problem for walking and activity. And it's like a vicious cycle. And also they get isolation, they stay at home alone. This social isolation also increases the depression, anxiety, also causes of increased depression. And it increases the chance of having more problem. We need to break this cycle in different locations with different treatments. For example, for airflow limitation, we can use an inhaler to dilate and reduce the patient's symptoms and be able to move more actively. With coaching, with pulmonary rehab, with oxygenation, different angles, we try to improve the quality of life and break this vicious cycle. Then I want to focus on change the correlation between COPD and cardiovascular disease. They correlate together. And how much COPD can increase the cardiovascular disease? This study shows that patient with no COPD versus COPD, as you can see, almost 3 times more common to get coronary artery disease in patient with COPD. Almost significant 5 times more to have the congestive heart failure with patient with COPD versus people without COPD. What's that? When we see significant increase in the risk of coronary artery disease and congestive heart failure in patients with COPD. This study again shows that the correlation for mortality from cardiovascular disease and COPD. If we have different cardiovascular disease, for example, heart failure, coronary artery disease, atrial fibrillation, diabetes, pulmonary hypertension, it shows correlation effect of each of them with COPD and vice versa COPD, which can increase the mortality. It's not just COPD. When we treat the COPD, I will explain later on, we can reduce the mortality and cardiovascular events. My focus later on the cardiologist drug inhaler from when they have patients here, not usually groups. So the same as they started prescribing the jargons. Like prescribing diabetes medication, it should be enough to treat the COPD patient well. This slide talks about the effect of the COPD exacerbation on cardiovascular event. For example, if the patient has a moderate or severe exacerbation, it increases in the first 30 days. 4 times increased risk of cardiovascular event, which means hospitalization from ACS or cerebrovascular. In the third in 1 to after 1 month up to 3 months, it increased twice and it stayed twice. Severe exacerbation is the time the patient comes to the hospital. Any patient who is in the hospital with COPD exacerbation, in the first 30 days, first one, 10 times increase the cardiovascular event. After the first month, still in a significant increase compared to the people without COPD exacerbation. It's not just COPD. If you treat the COPD, you prevent the cardiovascular event. Why is that? What's the correlation between these two? When patient comes with the COPD exacerbation, obviously in COPD is inflammatory. They have inflammation in their heart. they release the cytokines. Cytokine release can increase the process of atherosclerosis, can increase the risk of blood rupture, cardiovascular. Also, we get hyperinflation in the chest. When we get hyperinflation, obviously it reduces the preload and it increases the afterload. The workload of the heart goes up and it increases the cardiovascular. At the same time, the patient is hypoxic. The work of the heart goes up and the oxygen is low. Then it increases the cardiovascular. Again, the same story. COPD exacerbation can cause the hyperinflation, hypoxemia, systemic inflammation, arterial stiffness, exercise intolerance, and dysfunction can increase cardiovascular. They share the same risk factor. Smoking is bad for the COPD, is bad for the cardiovascular. Lack of activity is a very system. And anything else, increased risk of atherosclerosis. Exercise intolerance and systemic inflammation. What we can do in 2024. The goal of the population with COPD is to not only relieve the symptoms, we want to improve the exercise tolerance, improve the quality of life, improve the health status in the protocol, but also we want to reduce the mortality. This is a big change in the guidelines in 2024. We did not have any medication to reduce the mortality. Nowadays, we have medication. We need to think towards the population when we prescribe the medication. This is a change in the Canadian guideline, came end of the 2023. We have 4 pillars that we choose our treatment based on these 4. One is the history of COPD exacerbation. As I explained to you, I showed this slide. If the patient has history of exacerbation, it increases the mortality, increases the risk of exacerbation. It's very important to clarify that. There is a good study in Canada. 60% of the Canadian patients who bleed, they do not disclose their COPD exacerbation to patient, to a physician. You need to specifically ask the patient. All the time in my clinic, ask the patient, did you have any fear of the COPD? No, I check the cognitive on Friday. I asked them, I also look at the patient history. If they have any prednisone or antibiotic therapy, I also might have a prednisone. So at this time, I choose also more congested my prescription. This is a moderate exacerbation. Then we get antibiotic or prednisone. If they come to the emergency chamber, if they are connecting or if they have any emergency department, this is what they never mention that 60% of Canadian with COPD do not mention that we are physician. The second part is the symptoms. MMRC is in 0 to 4. Previously was up to 5. It changed that was MRC. So MMRC up to 4 to be equal to the cardiology scale. 4 is the time the patient gets off the summit with a maximum, with minimum exertion. I will explain to you and show you the slide. And then 1 is when the patient has shortness of walking on a flat at all. Not on a flat, then walk up inward steps. And the CAT score is a COPD assessment. Let's go into later on, it comes from 0 to 14. And the lung function is based on the FEV1. When you confirm the ratio is less than 70%. If the FEV1 is above 80%, is mild. If it is less than 30%, it's severe. I will show you later on the scale. And you choose this score. And you put in this scale, we go with the most one. What's the which one of these 4 gets higher number? You go with the most situation. If the patient, for example, has MMRC 2, but the CAT score is 30, you go with the 30 CAT score 30. Or the patient has no symptoms but has history of exacerbation, it's still considered high risk. And you go with the higher number for the treatment. Everybody should be on low-acting, short-acting bronchodilator. Everybody should get counseling for smoking cessation, for exercise, and everything. Right, the salt modification. Everybody should be on long-acting bronchodilator. It's a big change from the previous one. Previously, people did not have on daily basis symptoms, they go with the short acting as needed. Everybody's COPD should be on long acting. Canadian government doesn't mention LADO or LADO. Gold government suggests LADO because LADO control better symptoms than the disease. But Canadian government doesn't. As well as the mission is a long acting bronchodilator as well. This is the Tracker score on the left. On the right side, it has 8 questions. Start from when the patient's symptoms are less, get 0. When worse, goes up to 5. For example, if the patient never cough, get 0, they cough all the time, 5. 8 questions, 5 up to 5. Total score is maximum. The worst situation is 40. The best situation is 0. If it is above 10, patient is not doing well. We should not do anything. This is the MMRC. MMRC for isolation is a patient with minimal exertion because of changing the dress or turning from this one side to the other side of the bed. Because this is MMRC4. MMRC3 is the time that the patient has shortness of breath, walking on a flat level, even less than 100 yards. If the shortness of breath happens on a flat level, beyond 100 yards or 100 meters is MMRC2. If the patient does not have shortness of breath on a flat level, but gets shortness of breath walking uphill or stairs, climb the stairs, is MMRC1. I asked 2 questions of my patient. I asked them, do you get shortness of breath walking on a flat level? If they say yes, they ask them how far you can walk without shortness of breath. If it's less than 100, it's 3, beyond that 2. If they don't have shortness of breath on a flat level, the second question is, if you walk on a uphill or stairs, you get shortness of breath. If you get this, yes, is 1. If no, no shortness of breath at all. Just a question doesn't take much time in your clinic. How we treat it? We clarify the algorithm based on the previous slide I showed you. Then, if the patient does not have any exacerbation and does not have any significant symptoms, the CAT score is up less than 10, or has an expansive MMRC1, still the patient should be on long-acting bronchodilator, single lab or lab. I don't think we see this type of patient at the hospital. My main focus on this group, the green color, the highest patient. Patient comes to the hospital, emergency department, or hospitalized, and they are symptomatic. They should be on single inhaler treatment drug. 1 inhaler with 3 medications. Inhale corticosteroid, long-acting bronchodilator, LABA, or LABA. I see a lot of patients coming to the emergency, coming with a Spiriva, sent home without a Spiriva. We should not do that. It does not reduce the mortality. We are living in Canada. We are not living in other countries, developing countries. Then this is the main reason the Canadian government is different with the goal. We think we can reduce the Canadian mortality. We think it's worth it to make it a bit more expensive for the patient and fast for the government, but it's worth it. We can reduce the mortality nowadays. We did not have any medication to reduce the mortality previously, but nowadays we have the medication. We should try to reduce our clinical mortality. Any patient comes to the hospital with COPD exacerbation on the discharge, they should be on treatment, single inhaler treatment. There are 2 options we have: candle, trilogy, or rescue. If the patient, despite being on single inhaler treatment therapy, is a separation, the next option is we can add azithromycin. If they have chronic bronchitis with low FEV1, we can have Daxos, and we can use any acetylcysteine. Daxos is not popular because of its side effect. It can cause GI upset, weight loss, and energy, but it's an option. Azithromycin, you need to pay attention to the QTC interval, and if the patient has a MAC infection or any multiple process bacterial infection. These 2 are kind of one medication, or we need to adjust. Sometimes we get question from the pharmacy, the patient has QT pressure or does not have, is not quite observed. Anything, sometimes we cannot adjust the symptoms, so I must have a decision to change the other medication to reduce the risk of QT prolongation. Because they have more options, but for COPD, the only antibiotic we have is symptoms. We don't have symptoms. If the patient is low risk, which means that maximum we have one episode of moderate exacerbation, outpatient, not hospitalized, and symptomatic, they start with level alcohol, lower bronchodilator, like Onrelito, Inspirito, Altimbro. If they get exacerbation, they should be on single inhaler treatment therapy. If the patient has asthma COPD, and this yellow column, they can go instead of that, they can go with IC style. But pre-oiling or different, different things we can choose for IC style. Everybody should be on short-acting bronchodilator. Why did these changes came? It came from two major studies. One's called Impact, published in 2018, and the other one called PISOS, published in 2020. Both of them had quite big, large number of the patients reported in this study. 10,000 and more than 8,500. The Impact study looking at combination of the trilogy compared to, they are not comparing to no medication. They are comparing to taking patient dual dilator like ICS-LAMA or ICS-LAMA. The treatment therapy is not compared to the no medication class. It's compared to dual therapy. Comparing the treatment therapy strategy to real reduced by 15% compared to Amrilo reduced exacerbation by 24%. The next stream, they comparing to Semiko, combination of the evolution of forbiturol, and then we don't have it in Canada that already forbiturol. And again, the same, they reduced by 24% compared to lab and 13% by I6 lab. And again, hospitalization 16%. This is from combination of the trilogy. This one is for girls. This is like looking at all-cause mortality reduction. Comparing this slide, the left side is trilogy. Comparing to dual therapy, for example, you can see it can reduce 28% mortality compared to Amrelica. And the other side, the right side is registry comparing to Symbicort and the one we don't have the it can reduce 46% more hospitalization of all cause mortality. Huge reduction in 1 year. In this slide, when we pay attention to other medication can reduce the mortality. For example, cardiologists always have prescribed you simvastatin or Ramipril. How much it can reduce the mortality in 5 years? In 5 years, simvastatin can reduce 1.8%, or Ramipril 1.8%. In 1 year, trilogy was able to reduce almost 1%, and the same for rescue. If you multiply by 5 years, it's significant. Somebody may say, okay, it has a steroid. Why should the patient not be a steroid? This is looking at the steroid. Every time they get exacerbation, they are treated with a prednisone. Versus you give the patient IC-1 the effect of the prednisone on, for example, side effect, absolute risk for adrenal effect of corticosteroid or adrenal corticosteroid or steroid effect. You can see it's significantly worse with oral corticosteroids versus inhaled corticosteroids. Although it's microgram, it's not milligram, it's 1,000 less. And it's a 15 milligrams elevation for 5 years from the 200 milligram dose. This one is the microgram, 1,000 less in a One of the question comes, when patient is currently on dual therapy, on Wellington, the effects observation, should I add a separate, for example, ICS? Or I should put the patient on a single inhaler with triple therapy? It's a very common question in the practice. Patient is completely familiar with this inhaler, do you want to add another one or change it completely? This is they are looking at single inhaler, triple therapy with on the left side trilogy, and the both sides is trilogy. Comparing to multiple inhaler, and they look at the result for percentage of patients with improvement in the health stage. Also, as you can see, single inhaler is much more effective than multiple. And again, looking at the single inhaler triple therapy versus multiple inhaler triple therapy for FEV1 lung function. Again, we see more effective single inhaler triple therapy rather than multiple inhaler triple therapy. This is the reason that the Canadian guidelines suggest if you want to put the patient on in triple therapy, it should be single inhaler. We are looking at the risk of exacerbation again, single inhaler triple therapy versus multiple inhaler on different things. Moderate to severe exacerbation, moderate exacerbation, and severe exacerbation. Again, single inhaler triple therapy was able to significantly reduce exacerbation. The last part on the right side, looking at the mortality, all-cause mortality from single inhaler triple therapy versus multiple inhaler triple therapy. We are not comparing to dual inhaler, down or anything. Both of them, both groups receive triple inhaler triple therapy. I see example that one. One group is single inhaler, multiple inhaler. Again, we were able to significantly 33% reduce the mortality in single inhaler. Why do you think this is that? Patient adherence and compliance is the main key. When you prescribe multiple medication, the patient does not take the medication. When it's, for example, trilogy is 1 puff once a day, it's much more compliance and adherence. Okay. What we can do beyond the inhaler therapy for patients? My patient, the same as I showed you, is on triple inhaler therapy, which is still good. Exacerbation and had to emergency department this year. The patient comes to the emerge, is already on triple therapy, what else? Obviously, as I mentioned, triple therapy is the main change. We put the patient on that. Beyond that, if the patient is a smoker, the same as the patient I explained that the case Sam I showed you in the beginning was still active smoker. If we reduce and talk about encourage the patient for a smoking cessation, it's not easy, but it's worth it to try to switch it and interaction with the patient. If they stop smoking, it can reduce the mortality. And also it can reduce the quality. For mercury, it should be less than 4 weeks from hospitalization. So if it's after 4 weeks from your hospitalization, it's not as effective. We want to start with some studies suggest as soon as the patient in the hospital is starting pulmonary resistance. Fortunately, we don't have it in there, but there is a good thing since winter 2024. There's a website. You just highlight on your computer, Fitness for Breath, and all the content. Just Google it, Fitness for Breath, Lung Health Foundation. They have 3 services. There is a pre-recorded exercise. They can look at those videos, half an hour to 1 hour to learn how to do that. There is a group session. They will discuss how to manage the COPD and asthma as a group. And they can dedicate the physiotherapists for the patient. It's virtual. By the camera, the patient can log in and they can register them. The dedicated physiotherapist, they assist the patient, then they give them instruction for exercise and watch the patient while they do the exercise. It's free. They don't need to pay anything for that service. It wasn't free previously, since they had to learn from floor rather than stepping on the painter. They can leave the spot. It's not to each person, which system so fast. They need to register quickly to have that access. So fitness program. The other thing is oxygen therapy. If the patient in oxygen is low, based on the guideline, we can apply for that and put the patient on oxygen. If the patient is hypercapnic and they are CO2 returning, one of the options is not in active exacerbation, it's at a baseline. Because one of the reasons I get all the time from hospital, the patient comes with CO2 with COPD exacerbation, has COPD and has elevated CO2. The CO2 elevator should be at the baseline time between the patient comes with exacerbation. If it's elevated, sometimes I ask the patient with a sit-in walk test when they come to the hospital to do AVH. If they have elevated CO2, it's a good option to go with the bicap. The target is normalize the CO2. If you cannot normalize the CO2, it does not improve the mortality. And most of them, if they don't have any obstructive sleep apnea, looking at the data from the bicap needs to go, because there is no age violated to look at that to see if the patient's doing good or not. You need to look at the CO2. You need to normalize the CO2 in the partial. Lung volume reduction. Unfortunately, we don't have an final endoscopic lung volume reduction. It's not funded, but the surgical version is available and lung transplant. Talks about endoscopic lung volume reduction and how we plan which patient is eligible for transplant or anything, but we don't have lung volume endoscopic version. We have a surgical version, surgery. If they are more operable, redundant, or they have good, then transplant. What else we can do for the patient? The newer studies, we are looking at the biology. Most likely you are familiar with the for asthma. A group of patients with COPD that have elevated eosinophil count. If the patient eosinophil count is elevated, show that they have T2 what's called T2 inflammation. And we have an option for treatment. People with elevated eosinophil count, they have high risk of exacerbation compared to people with lower eosinophil count. When they put the patient in the various study, patient with elevated eosinophil count and COPD exacerbation, they had exacerbation 2 or more in the prior year. They had significant decline in exacerbation around 35%. And also there was significant improvement in the pulmonary function test. In the NOTICE study, again, very similar design again with the dopilumab, patient with moderate to severe COPD with frequent exacerbation. Again, the dopilumab was able to reduce the exacerbation and was able to increase the interval to the next exacerbation. So it's every 2 weeks injection. It's not daily basis, just every 2 weeks. It looks like the equipment the patient can issue about this. This is a study that kept the vetolizumab or Nutella. You are again familiar for Nutella for asthma patient. They tried that for patients with COPD and elevated dose in the ground. Again, it was able to reduce by 18% exacerbation. They checked different dosage of the 100 milligram versus 300 milligram. There was Masoud, both was able to reduce exacerbation. The dose we use for asthma is 100 milligram. It's against something we would have inject every 4 weeks. Dopilumab is every 2 weeks injection, localized every week. Unfortunately, still, we are not approved by the AG in Canada, but if the patient has asthma, COPD, and booster. Bottom line is how we can help the patient with the COPD. When the patient comes to the hospital, they have severe exacerbation, increase significant risk of mortality, lung function decline, reduced quality of life. First, we need to have accurate diagnosis. But still, I get lots of referral from patients with COPD. They mark as a COPD for 20 years. They come to the emergency department 10 times in a year. They don't have the PFD. When you want to discharge the patient, if the patient has COPD exacerbation, at least recommend the family physician to do a PFD, a spirometry. Doesn't mean the full PFD, spirometry. Many patients have, they mark as a COPD, they did not have COPD. Many patients. They have bronchitis, they have many different asthma, many things they can have, but they mark as COPD. The treatment is here. First, the diagnosis should be covered. First, the treatment is based on the severity of asthma, exacerbation, and right explained to you. The patient should be involved in the treatment. If you prescribe the best medication to the patient, if the patient cannot take the medication correctly, it's not going to work. The technique is important for being here. It's different from the pills. The patient should be able to take the medication. They need to see that I have in my office different inhaler with different devices to which one patient can follow and take the medication. But if you prescribe the best medication, for example, it's very common scenario in COPD, there are elderly that have dementia, they cannot coordinate the actuation device. Which device is best for this patient? This is the patient is okay, they coordinate, or on the other hand, the patient has very advanced COPD, they cannot take a good negative respiratory pressure. Which device is better for this patient? Your iPod or minor? You should choose single inhaler treatment from rather than multiple. It improves the mortality, it reduces the exacerbation, and increases the adherence of the patient to the treatment. The device are patient, if the patient is no how to use it, it's better to choose something more familiar with the patient. Then we ask the patient, see in the office or we can ask the patient and discharge having a physician to follow the patient, see if it's able to take the patient correctly and how much is covered. Again, to summarize, this is the last slide. COPD has high mortality. The aim in Canada in 2024 is not only to relieve the symptoms, reduce hospitalization, reduce mortality. And they will have patient this slide severe COPD and patient comes to the hospital. My thought, because it's a hospital setting, that to outpatient, I didn't talk about much about my asthma, my COPD, or my COPD mainly for the COPD exacerbation. When the patient want to go home, should be on single inhaler triple therapy. I have seen many patients from single hospital, we already have seen the console, like recommend that. When the patient goes home, it goes back to the medication camp here. If the medication was good, the patient wasn't here. We need to have an open conversation with the patient. The life expectancy is in the patient. We need to be honest with the patient. We need to do our best for the patient. Encourage for exercise, oxygen, many of them they don't want to active. It's not good because some places have short summer. But if the patient knows that they're doing activity, exercise, they can improve their quality of life, they can live longer, without being to do. Again, it talks about single inhaler control. Thanks so much. Any questions?
Okay, do you have any questions for Mahdavian? I got a couple, but I'll open up to the crowd first.
Any online before I get going? So with the triple therapy, so I mean, it definitely sounds like, is it only compliance? Is there any benefit of just having the bronchodilator and the inhaled steroid at the same time?
Yes, it has three medication. It has an inhaled corticosteroid and also has two bronchodilators from two different mechanisms. When we do the bronchodilation, we reduce the hyperinflation. Patient can have better deep breath versus they have air trapping. And also they have less resistance for airway passage. They feel less shortness of breath. It can improve their symptoms. And also ICS, inhaled corticosteroid, reduces inflammation in the airway. Because as I mentioned, COPD is an inflammatory disease. You add growth and aspect of the problem. But there are some studies we are looking which patients, for example, can get better from come to the hospital from ICS versus antibiotic. They are looking also at CRP. For example, patients with elevated CRP, they get more benefit from antibiotic. If they have more CRP, they don't need to get antibiotics. It does vice versa. The same for bronchodilator. There are more studies coming. Guideline may change. Based on the current evidence we have, the suggestion is for patient with frequent exacerbation, combination of inhaled steroid and two bronchodilators is the best option.
What's the cost for Trilogy for these combo drugs?
Just better to ask the companies. I don't know that. Most of the patients with COPD are about the age of 65. They don't pay anything for the medication.
So this would be covered under the
term which is covered, just use the LUO. Same as breastfeeding, both of them are covered by the LUO. If the patient has ODSP covered, then most of the insurance covered them. If the patient is younger than 65 and it's not covered, that's nobody you want to go to another 20 years, something longer.
Usually that does around $130 for
$130. If you want to start two separate inhaler, for example, ICS level plus platform, it's going to be much more expensive. So multiple inhaler therapy costs more the patient.
But the same thing I did in their moderate severe person who maybe wasn't on a trilogy or a triple therapy focus unit. You treated with oral steroids, antibiotics maybe, and the short-acting bronchitis. You know, the class practices, you would keep them on their long-acting in the background. When do you start the long-acting before they leave? Do you wait till they're done the oral prednisone, or would you start it
Prednisone, long-acting bronchitis, long-acting prednisone is COPD is contraindicated. It's not asthma. If it is mortality, and you can see, do we have access to this?
Maybe he's left, Mitch is gonna sub in.
Here, I'll thanks.
Everybody should be on protecting as long term. Prednisone is contraindicated. Many a study for the last 7 years, all of them show the side effect is more than benefit. If the patient has minimal symptoms, the still should be on long-acting bronchodilator, no ICs, like Spotting or Brisbane or Spotting. I never start completely. Simply, any of those long-acting bronchodilator. Then, if the patient has history of one exacerbation, mother, over the last 12 months had one exacerbation, not two, or no exacerbation, but has shortness of breath walking on the battlefield, or catastrophic walking, should be on dual form of therapy, not single one. It's for the first time you see the patient. It's not the step up. You see the patient for the first time, and you find the patient has COPD, Has shortness of breath, walking unflattened, should go home with a 2 bronchodilator. No exacerbation, no ICU. This is the minimum here. If the patient comes to the hospital with exacerbation, then you go with the treatment.
Any other questions for David?
Single inhaler therapy.
There is a trilogy element. And the second one is a breastfeeding aerosol. Very good question. Actually, I had tried for how to choose, it's a theory talk, how to choose the device. We have many different types of devices. Why choose this device for this patient versus that? As I mentioned, first, if the patient knows the device previously, knows that device for that we can go with that. For example, if the patient using Advair or use the salbutamol frequently and no one using correctly, but first is going to be, for example, first. That's one. The other thing is patient's probability. The little device is the simplest device for taking the medication. I wish I had the device here. You just push the cap to the side, as far as it makes it clean, the patient you breathe out, put it around, take the deep breath in, hold the breath 6 to 8 seconds, breathe out, watch the mouth, starting to down. Down. When it's open, they shouldn't turn it down, they shouldn't cover the breath. Very simple, easy. Many patients that have difficulty to coordinate between actuation of the device and inflation. It's very simple for them to use the device. Many patients, if the device has multiple steps, each step you add makes it more chance of mistake. The device is very easy, has to. But if the patient has very advanced COPD, cannot show a good negative spread depression because of the internal system of the device, that is the NTR. That was first. The second reason I choose the breastfeed. Some patients, despite taking their once a day, in the morning, still they wake up at night with some symptoms. They don't have 24 hours coverage of medication. They feel it's not working for their 24 hours. Breastfeed is twice a day. They get punched in the morning. But when you increase the number of the time the patient take the medication, you reduce the adherence. Lots of parameters you need to consider in water system. If it's twice a day, the patient doesn't wake up, but does the patient take the medication twice a day? It doesn't work for it. Works 24 hours, very easy to take. Majority of patients have enough still respiratory pressure to take that. It's covered by the OA solutions. Breastfeed is there as well. It's a patient experiment with the salbutamol to create a painkiller. That's the good technique. If they don't have the technique, they can use the air spacer chamber. For example, the same as kids, when you prescribe inhaler for asthma, kids, they use the mask. They use that for some patient has the initial paper. Some patient has advanced initial kind of paper medication. They can use the breastfeed with a mask and chamber. The same as kids. We need to think, for example, I have patient doing good on breastfeed, but because of the rheumatoid arthritis, they have some problem they can't handle anymore and should be worse. And talk to them, it's not just a long, we need to think of as a whole application. And not actually has a deformity or has been good, but now come with a fracture, hand fracture, bone fracture, maybe, and they cannot fracture. Like this.
Good question. For azithromycin, do you screen for mycobacterium?
That's an excuse culture for plantation.
What?
Many physicians in Canada look about guidance. The more important is QT feasible. Most of the patients may come for there, say IBCG, and is able to see QTCs for one. But CBC also feels any patient is pretty much has a CBC. And easily look at it also very common. For asthma, for COPD, but usually a diagnosis for T2 by inflammation. Some studies suggest if the patient doesn't have elevated dose of glucose, doesn't need a diagnosis. considered. It's not being done.
Thanks very much. One more round of applause for Masoud.